All right, let's jump right into section 2.6, other systemic connective tissue diseases. We're skipping the slow-paced basic textbook fluff today because we're here to do one thing: map out the exact physiological mechanisms directly to their clinical manifestations. Why? Because locking down this specific architecture is exactly what's going to secure you that 270 plus on your USMLE's Step 2 CK. Let's get right to it.
So let's drop straight into a diagnostic sequence. Imagine this. A 28-year-old female presents with pleuritic chest pain, a facial rash that noticeably spares the nasolabial folds, and an elevated creatinine. The question is, what is the single most sensitive initial test? Look at the clues we're dealing with. You've got a young female with serositis, that's the pleuritic chest pain. You've got a very specific skin finding and acute renal impairment. Before you can even start thinking about treatments, you got to nail that absolute best initial step. We are staring down the prototypical autoimmune disease, systemic lupus erythematosus, or SLE.
Now, SLE can literally attack any organ system, but you absolutely have to instantly recognize its classic multi-system cluster. Think of it in three parts. First up, the skin. We're talking about the malar rash, a continuous red to purple plaque across the bridge of the nose and cheeks that crucially, strictly spares the nasolabial folds. Second, the joints. You'll see symmetric inflammatory joint pain, but unlike rheumatoid arthritis, it's typically non-deforming. And third, the kidneys. Lupus glomerulonephritis is actually the most common cause of morbidity in these patients, usually presenting with hematuria, proteinuria, and that elevated creatinine we just saw. Just picture the cutaneous reality for a second. That bright red butterfly rash spreading across the face, but leaving those nasolabial folds completely untouched. You might also spot some painless oral or nasal ulcers, but honestly, the real life-threatening danger is hiding beneath the surface. It's the immune complex deposition in the glomerulus. It creates this intense, full-house immunofluorescent staining pattern that essentially just destroys renal function. Okay, so how do we definitively prove this? We have to walk the exact serological staging ladder. Step 1 is your ANA. This is your screening test. It's got incredibly high sensitivity, showing up in up to 99% of cases. But, a positive ANA doesn't just automatically equal lupus on its own. To actually confirm the diagnosis, we move to Step 2, our definitive, highly specific markers, anti-dsDNA and anti-Smith. Finally, Step 3, we check the immune system's fuel gauge by monitoring complement levels. You're going to see a drop in C3 and C4, and that's because the deposition of those immune complexes is actively chewing through your serum complement proteins. When it comes to long-term management, pretty much all these patients need to be on hydroxychloroquine for maintenance to prevent flares and limit chronic damage. But here's the absolute crucial takeaway. You have to keep a hawk's eye on those anti-dsDNA titers. Fluctuating titers aren't just some abstract diagnostic tool, they directly correlate with active disease flares and the acute onset of lupus nephritis. When you see those titers spike and the complement drop, standard care goes right out the window. That pattern dictates an immediate, aggressive immunosuppressive escalation, often utilizing drugs like cyclophosphamide or mycophenolate mofetil. Let's see how this actually plays out in a classic board vignette. You get a question about a young female with migratory arthralgias, maybe some fatigue, and a facial rash. The question asks, what is the most appropriate next step? This vignette intentionally forces your hand. You absolutely must choose to check a highly sensitive serum ANA first. Do not, I repeat, do not jump straight to the highly specific but way less sensitive downstream antibody panels like anti-dsDNA. You have to cast that wide diagnostic net first. All right, let's pivot to our second module, Sjogren's syndrome. This is a chronic autoimmune disorder that relentlessly targets exocrine function. It's driven by these destructive clusters of lymphocytes that just infiltrate and wreck the glands. Clinically, what does this look like? Well, you get keratoconjunctivitis sicca, which is profoundly dry, gritty eyes that barely even respond to artificial tears. And you also see xerostomia. This is a severe dry mouth that leads to tongue fissuring and incredibly fast dental caries, often in really unusual, atypical locations in the mouth. To lock in this diagnosis, we're looking for a very specific serological footprint. Sure, you might see a positive ANA or even rheumatoid factor, but anti-Rho/SSA and anti-LAW/SSB autoantibodies, those are your absolute definitive biochemical hallmarks for this specific type of exocrine destruction. But listen up, because here is the most heavily tested long-term monitoring requirement for this disease. Patients with Sjogren's syndrome carry a massive, completely disproportionate risk of developing B-cell lymphoma. We're talking up to 44 times higher than the general population. That is staggering. This risk typically manifests as non-Hodgkin B-cell lymphomas, and they very often arise straight out of the parotid gland.
So you have to completely master this clinical split. On one side, you have your standard benign presentation: dry eyes, dry mouth, managed with artificial tears, lots of hydration, maybe some muscarinic agonists like pilocarpine. But on the other side, if you see new unilateral parotid swelling, localized lymphadenopathy, or B symptoms like night sweats, well, that changes the game entirely. That presentation forces the immediate choice of a tissue biopsy. You have to rule out malignant transformation right then and there.
Let's confront the actual clinical vignette you'll likely see. A patient with long-standing Sjogren's syndrome comes in with persistent, asymmetrical cervical lymphadenopathy. What is the next best step? Your mental rationale here must exhaustively prove why a lymph node biopsy is the correct and frankly only action to take. You're bypassing the standard reassurance. You're definitely not just adjusting their artificial tear prescription. No, you are actively hunting for that B-cell lymphoma.
Finally, let's attack Module 3, systemic sclerosis or scleroderma. This entire disease is driven by the excessive pathological deposition of types I and III collagen. And it strictly splits into two completely distinct phenotypic pathways, based largely on their catastrophic endpoints. We're looking at limited scleroderma versus diffuse scleroderma. On the one side, we have the limited phenotype, which you probably know historically as CREST syndrome. This is driven by anti-centromere antibodies. It features calcinosis cutis, severe Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. But crucially, and write this down, it carries a massive risk for isolated pulmonary arterial hypertension. Conversely, diffuse scleroderma is a whole different beast. It spreads rapidly. The widespread skin thickening extends proximally, going way above the elbows and knees. It's driven by anti-SCL70, also known as anti-topoisomerase 1, and it points toward incredibly lethal endpoints, specifically scleroderma renal crisis and severe interstitial lung disease.
Now pay close attention because here is the lethal board trap just waiting to catch you off guard. When a diffuse scleroderma patient goes into scleroderma renal crisis, which looks like a rapid onset of high blood pressure, oliguria, and acute renal failure, your very first instinct might be to reach for the immunosuppressants. Do not do it. High-dose steroids are strictly, absolutely contraindicated here because they will actively precipitate and worsen the renal crisis. Instead, the absolute savior for this specific hypertensive emergency is an ACE inhibitor. So I'm going to leave you with this final provocative thought to test your active recall. If a diffuse scleroderma patient presents with rapidly progressive oliguria and acute hypertension, and you administer high-dose steroids, what fatal physiological cascade have you essentially just authorized? Yep, you've just thrown gasoline on a sclerodermal renal crisis. Master these rapid-fire diagnostic branches, deeply respect the absolute contraindications, and let this architectural understanding guide you straight to that top-tier score. Keep reviewing the material, and I'll catch you in the next explainer.